going to do differentiating anemias, which is fairly minimal. I think when I'm just kind of doing a little bit of meta-analysis of the tests this time and taking a look at it, I think what helped more than anything was the fact that I really increased the number of questions on the test. So I'm going to try and make sure multiple choice are at least 30 to 50 questions per test. Sometimes, I mean, there's only so many things I can ask and so many ways I can ask it. And I try not to put the same question on too many times, because then if you get somebody who didn't get that particular concept, then you've really, you know, given them a bad day. So I think that helped a lot more. I'm going to just go back to what I was doing before, but please remember the PowerPoint study guides are on there. They're not the greatest, but the answers are posted as well, okay? If you have any questions, please feel free to text me. I know it's the holiday weekend, but I'll be at work all weekend, so I'm not doing anything else exciting. So please feel free to text me. I'll get back to you within a couple of hours most of the time. There may be a few times when I'm supposed to go to my brother's for a barbecue and I may be in a food coma for a while. There's 3 of us going. He'll have enough food for at least 15. Last time we went, he made a ham and a turkey breast, and his appetizer was a seafood gumbo. Plus side dishes, plus, yeah, I mean, you know, I rolled out of there to work. I'm like, I don't want to. Would you bring us some? Yep. He didn't make food. So anyway, I'm just going to go with the same step, just tell you what was on them. I am going to increase the number of questions. Again, do not hesitate to email or text me, but don't get ticked if I don't get back to you instantly. I will be at work. I do have to work sometimes. They make us actually do stuff once in a while. Let's see, what else? Anything else?
You got us back.
I will have to give them back Tuesday because I have people who have not taken it. So I cannot give them back until. Your grades will be posted today. Probably by 2 or 3. Because after you guys leave, I'm going to hang out here, grade things, and get caught up on some stuff. Yes.
So are you still going to take questions from this test then? This last one? Where
I didn't see any that were particularly needed to go on to the next one. Okay. The lipemia question too, y'all get it. That one's going to keep showing up, by the way, in one form or another. But yeah, there were none on this one that sort of everybody missed. Everybody kind of missed different things. I made new slides last night. The good news is the white cells look lovely. Bad news is the red cells are blue. I have no idea why the red cells are blue. I don't care why the red cells are blue. The white cells are the right color. They all look good to Tiana. Tiana, you'll love the red cells. They're great, yeah.
Yeah.
They're actually more kind of a gray. So it is nothing to do with these patients. It's just that the slide standard, we changed the crystal violet after I did these slides, and the new slides looked a lot better. But quite frankly, I had already made these and cover slipped these. Y'all can just ignore the blue. It's the white cells we're looking at anyway. Monday, I would like to draw blood. How do you feel about a CBC practical on Monday?
Tuesday?
Tuesday. Yeah, you're all going to be watching fireworks on Monday. Tuesday. How do you feel about a CBC practical? Just one CBC, one and done.
Not a normal diff.
Huh?
Not a normal diff.
No diff,
Oh,
just the CBC.
okay.
Just the CBC? Okay. All right, that'll get the wet work done. So Tuesday you'll have to wear your scrubs. The rest of the week, next week, Wednesday and Thursday, you can wear your t-shirts. All right. Not a big PowerPoint. did have some extra ones printed out if anyone needed one. I'm not sure where they went, but I did have some. Just like we talked about differentiating leukemias, I want to talk a little bit about an overview of differentiating anemias. This one is a little bit more of an algorithm, and everyone kind of has their own way of thinking about it. One of the things I want you to kind of create in your own mind or for yourself is some sort of logical progression of what testing you do, why you would do it, or how you would sort of narrow these down. There's a bunch of different tests we can do. We're going to talk about all kinds of things as we go through here. Anemia, literally, if we break it down into its component parts, A or an means without, and emia means in the blood. So anemia literally means without in the blood, or without blood. Anemia is a decrease in oxygen carrying capacity. Why? Because what do red cells do? Carry oxygen. There's a couple of different reasons, and we'll go into each of those. Anemia is a symptom. You don't just have anemia. Something is causing the anemia. Despite the fact that ICD-9 gives us its own, or ICD-10 now, gives us its own code, anemia is not a disease. It is a symptom of something else. It's actually a compilation of diseases. Okay. There are a couple of ways that we can classify anemias. The first way we classify anemias is pathophysiologic classification. In other words, what causes it? And there's basically three things that are going to cause anemia. Either we're losing blood, bleeding being one of them, or hemolysis, and we'll talk more about that later. Inadequate erythropoiesis, in other words, we're not making blood. And the third way is abnormal erythropoiesis, or we're making blood but it doesn't work good. So these are the pathophysiologic classifications. And every anemia is going to fall into one of these three. Clinical manifestations, in other words, what do we see? Weakness, fatigue. One of the most common reasons people come in is simply good old TBS, tired butt syndrome. I'm just so tired and I don't know what's wrong with me. Depending on how far along this is, we're going to see different things. Dizziness can result. Obviously, anytime you lose enough oxygen to the brain, you can get dizzy or have syncope. Pallor, you're going to have people who are pale. Now, some people are more naturally pale anyway, but these people can turn like almost white. Yes?
What is
Syncope is dizziness, or, you know, it's like somebody's going to pass out. Headache. A lot of these anemias will give you a headache. SOB is not a comment on your personality. What does SOB stand for?
Shortness of breath.
Shortness of breath. Okay. Organomegaly, not in all. Right. This is going to be in specific ones. Pretty much all of them you're going to see weakness and fatigue as it goes along. If it gets far enough, you're going to have dizziness and pallor. Headaches vary more patient to patient than disease to disease. Short of breath is going to happen in almost all of them just because you're not carrying enough oxygen. The other one, if it gets far enough along, we can actually see atrial fibrillation and ventricular fib as well. So we can see the heart flutter. It won't pump quite as well.
Is that because it is also getting a lack of oxygen?
Multiple reasons. Number one, your blood is, it's having a hard time because it doesn't have enough to push against because it's so literally thin.
That was like that.
It can be, yes.
Okay.
Yes, it can kill you.
Would getting a pacemaker help in that situation?
No.
I didn't think so.
No. fix the anemia. That'll help. Diagnosis. These are very important things. This is, again, while it's important when we're diagnosing our leukemias, history is even more important when we're talking about diagnosing our anemias. For one thing, there's a lot more of these than there are of the leukemias. There's what, 20, 30 leukemias that we talked about? And that's pretty much all of them. There's literally 50 to 100 anemias, and probably more if you start cutting it down into subcategories. A history of bleeding. You know, we don't know why she's anemic. Well, she told the cleaning lady her periods have been super heavy for the last 6 years. Honestly, we had an 80-year-old lady who came in with severe vaginal bleeding. She didn't tell the doctor. He wasn't that kind of doctor. Seriously, he wasn't that kind of, he wasn't a lady doctor. He wasn't an OBGYN, so she didn't think he needed to know. That kind of explained why her hemoglobin was 5. The nurse found out because there was blood all over the bed. Ma'am, have you been? Oh yes, I thought I'd gone through the change and I was over that. And you didn't think it was abnormal when it started again? Yeah. And it had been going on for a long time. My favorite line though was, he's not that kind of doctor. A family history of anemia. You know, perhaps there are many of these that are hereditary. So we do want to make sure that we're catching any of them that, you know, just run in your family. Duration of symptoms. Basically, some of these anemias come on very slowly. They're very insidious. Others come on suddenly. Again, just how long you've been having this problem, let's take a look at it. Lifestyle. Why would lifestyle matter? Your work, your hobbies, what you eat. Iron's one thing, nutrition's one thing. What if I work in a lead plant? Processing lead. Lead poisoning leads to anemia. The guy who packed his own buckshot, and he still had the same lead pellets his daddy and his granddaddy had been using. He's suffering from severe lead poisoning. Medication history. Some people have extremely bad reactions to certain medications. Did you go anywhere? Malaria is a big cause of anemia. But if you haven't gone anywhere, you did not pick up malaria in central Illinois. But my cousin had it. That is not the way it works. Even if you go camping with your cousin and you both get bitten by mosquitoes, you didn't get malaria from your cousin. You gotta have the right kind of mosquito. It just don't work that way.
So it's not possible.
Huh?
It's not possible using bodily fluids if they drink after each other or something like that.
Not that. If you got a blood transfusion from your cousin, I guess that would do it. Or if, I don't even think if you were shooting up with your cousin, there would be enough of a blood exchange. Guys, you know, we got to look at all possibilities. I don't think even that would be enough. I don't think there'd be enough on the needle.
So it's not bodily fluids, it's blood specifically.
It's blood. It's blood to blood. But it usually has to go through the vector because it does many of the parasites don't mature unless they go into the gut of the mosquito. So, I don't know. I have to look that one up once. Physical exam. Look for bleeding. Skin, hair, eyes, etc. This can give us nutritional clues. We'll talk much more specifically about those. Do we have organomegaly? Or sternal tenderness, and sternal tenderness could be because of organ swelling and other things. Okay? So physical exam. What are we going to find in hematology? The first way we talked about classifying anemias was what? Both minutes ago. What causes it? Etiology, pathophysiology. Okay. We can decipher it by what the cause is. The second way we can classify anemias is based on their indices. Okay? I know Jean started working with you in 150. That if your MCV is high, it's macrocytic. If your MCV is low, it's microcytic. We can classify our anemias based on what size and how much hemoglobin is within our cells. We have micro-hypo, that's the most common combination. Usually if they're microcytic, they tend to be hyperchromic. We have macrocytic normochromic and normocytic normochromic. The problem is that sometimes you don't have just one anemia. So if we have B12 folate deficiency, one of the megaloblastics, and we have an iron deficiency is micro-hypo, and megaloblastic is macro, and so we wind up with normal. No, what we wind up with is macrocytes and microcytes. So we can classify them based on our indices. And yes, you need to kind of figure out as we go through these, both. So you're going to need to be able to place any given anemia into its etiologic or its pathophysiologic classification. And those three classifications are you're losing it, you're not making it, or you're making it bad. And when you break it down to it, that's really what you got. Or classify it based on what cell size and shape we normally see. Peripheral smear morphology is going to give us quite a bit of information. Oh, I skipped the obvious. If your H&H is not decreased, you're not anemic. I had a student who told me, oh, I'm always anemic. Her hemoglobin was 12.6. You're not anemic. Oh, but I'm always tired. Well, then there's got to be something else going on. You're not anemic. You have to have a decreased H&H. That's the definition of anemia. Right? Your peripheral smear morphology, anisocytosis. What's anisocytosis look like?
Size.
Big and little. Size differential. Okay. Or are they all big? Are they all little? Are they varying sizes? What's the RDW? Does anybody remember? And where do I get it? The computer tells me, yes. And what is RDW? Red cell distribution width. And what's that going to tell me? That's going to tell me how different in size my cells are. So in a perfectly normal person, I'm going to have an MCV of 90, I'm going to have an MCH of 30, an MCHC of 33, and an RDW of about 13 to 15. That means all of my cells are about the same size. Okay. If I can have somebody who's got normal indices, but whose RDW is elevated, and that tells me I've got big ones and little ones. That case I was telling you about, if I've got somebody who's got macrocytes and microcytes, where the numbers are going to give me a normal MCV, but my RDW is going to be really high, telling me that even though my numbers are normal, there's something funky going on. So I hand.
I thought as far as the RDW more normal it is.
No. Actually, I think the lowest RDW I've ever seen was 10. But yeah, it's really, you're looking at ones that are up over 17 or 18. Then you're starting to look at maybe, and it may be poikilocytes as well, but you're looking at cells of different size. So when it gets above, I want to say 20 is when we look at our slides. They may have increased it by now. But it just kind of tells you if you want to take a look at it to see if there's something weird looking. Poikilocytosis is important. Many of these anemias that we're going to be talking about are very specific as to what the cells on the slide. If you've got hereditary spherocytosis, guess what you have on your slides?
Spherocytes.
Don't make it hard. You know, if you've got hereditary stomatocytosis, stomatocytes. Okay. So sometimes seeing if you've got one of our hemolytic anemias where our cells are busting open, you're going to see red cell fragments. What's the fancy schmancy name for those? Schistocytes. Yeah, so we're going to see schistocytes. And inclusion bodies. If I see malaria in your red cells, you have a problem. bodies, how jolly bodies, basophilic stippling, all of those can give us a clue as to what's going on. Other things, the retic count, and we are going to do this next week. This is very important. We're going to see an increased retic if you're losing blood. Why? Because your body's working to replace it. And like we talked about yesterday, normally it's going to keep those young red cells in the bone marrow. But if you start having oxygen deprivation, it's going to kick them little boys out, those little boys and girls out, and say, get to work. We need help. Go. And so you're going to have an elevated number of young cells in the circulation. The other thing we're going to use the reticulocyte count for is if I find out what's wrong with you, I determine that you have a severe iron deficiency. What am I going to do? I'm going to give you iron. Then I may do a retic in about 3 to 4 days, because if the iron is doing its job and it's working and you're getting better, it means your bone marrow is producing and my treatment worked, and we just keep up with what we're doing. It takes a lot less time to see a rise in retics than it does to see a rise in your hemoglobin. If I treat you and your retic doesn't rise, or if you have no retics to begin with, even though you're anemic and in need of oxygen carrying capacity, if my retic doesn't go up in response to a decreased H&H, something's wrong with my bone marrow. So one of the pathways that I know that people use to figure out which anemia we're dealing with is to look at reticulocytosis. Do I have retics? Do I not have retics? It's quick, it's easy. Honestly, how do we do it at work? It goes on the machine, and the machine spits out the number. Okay. Yes?
For sickle cell patients, isn't a retic a necessary test to see if they're in sickle cell crisis? So how does that affect? Why is reticulocytes affected by sickle cell?
Because if the patient's in crisis, they're hemolytic, the sickle cells are going to be bursting. That's what happens with sickle cell. And so the bone marrow needs to respond and increase the reticulocytes.
So it's constantly producing. Okay.
Yeah, and I've seen retics, normal for a retic is about 0 to 2.5, I think, something like that, or 0.5 to 2.5. I have seen patients in sickle cell crisis with a 29. So like almost over a quarter of their cells are new.
But the morphology of the retics is normal
Usually.
in sickle cell?
And until they start sickling. Yeah, until they start sickling. Basically, and we'll talk a lot about sickle cell when we get there. We can do a bone marrow aspiration and biopsy. It's kind of one of those things that's expensive and it's putting the patient through quite a bit. So we usually try to do as much as we can on the peripheral blood first. And then if we can't figure it out, then we're going to go ahead and do a bone marrow to see what's happening, especially if I see if I see a low retic and I suspect bone marrow involvement, then I'll do a bone marrow aspiration. But just because you're anemic, they're not going to give you a bone marrow. But it is another test that we can do. And there are a lot of tests. We will talk about each one of these as it becomes appropriate to the discussion. Iron studies, haptoglobin, Schilling's, electrophoresis, bilirubin, Raccoon's. Occult blood and fecal exam. What are we looking for in an occult blood test? Anybody know?
Blood and stool.
Blood and stool. Okay, why would we look for that? Well, if you've got a chronic GI bleed, guess where your blood's going? Ah, we found it. Okay. And a UA. Did you guys dip urines in 150? No, you didn't. Okay. One of the tests we look for on a UA is there hemoglobin present? So if there's blood spilling out into your urine, that's not normal. So we can figure out, well, maybe that's where the blood's going. These two we probably will not revisit, because really they're just looking for signs of blood loss. Okay. But the rest of these we're gonna talk about those more in depth when they hit which tests they are appropriate to. There are many algorithms available. I've got one that's a tree and the squirrel climbs up the tree and whatever. But there are a lot of algorithms that you can use. The thing you've got to do is find one that works for you. Okay, figure out a way, develop a systematic way to rule in and rule out. Make sure that you're reading the patient histories. Okay, I'm going to get, there's a lot of clues and we'll talk about them as we go through the different anemias. But there's a lot of clues that can be found in the patient history. This is from aruplab.com. The reason I use that one is because they let you go in and look at all kinds of stuff without having a client number. Okay. They have got some awesome and amazing information. They've got algorithms for CD marker type, for flow cell cytometry typing. They've got algorithms. Basically, these are designed for physicians to tell the doctor, here's what you start with. We've got a low hemoglobin. What are we going to do? We're going to do a retic, and if the retic is low, we're going to do this. If the retic is high, we're going to do this. Okay, so it tells them these are the things that you're going to do, and this is the recommended order to do them in order to maximize efficiency of testing. How do most doctors usually do it? Patients anemic, do an iron and a B12 folate. We'll start there and go on. I love the doctors who shotgun everything. I want an iron, a B12 folate, reticulocyte. I want, haptoglobin and FEP and all this other stuff. How about we do the CBC first? Well, his hemoglobin's normal. Why am I doing all this stuff? You will not be required to know this, other than you're going to use it for possibly doing your case studies. Yes?
The doctor doing the shotgun test just so that he's never confusing the patient. They get all their blood drawn on the off chance that their CBC is not.
Yeah.
Not
And unfortunately, insurance companies are cracking down a lot harder on a lot of this stuff. Basically, insurance companies now run what testing we're allowed to do. It's very much the insurance company says, nope, I won't pay for that. If your diagnosis code does not support that test, they ain't paying for it. So doctors, it's a game. They have to learn, and they just upped last year or the year before. They used to have something like 38,000 different diagnosis codes, and they went to 164 or something like that. And these days, if you go in and you broke your left pinky finger, but the doctor codes it as a right pinky finger, insurance can refuse to pay. Now then you got to go back and resubmit. But honestly, there's a lot of people who just don't want to mess with the insurance hassle. But yeah, I mean, very seriously, they are getting to the point. It is so difficult for doctors to even. It's like the doctor wants to do a simple test, and he has to figure out, well, what am I going to say she has? Honestly, fatigue. You put fatigue, you can order damn near anything you want, because that's a symptom for everything. All right, test on Tuesday. We're going to go over the lymphocytic leukemias and lymphomas. We'll talk about erythropoiesis. Make sure you know both categories and be able to match the two different nomenclatures for erythropoiesis. Just flat out telling you that that's going to be on there. So it's going to be 5 points or 6 points, however many stages there are. So don't miss out on the easy points. Again, feel free to contact me this weekend if you have questions. You all have my text number. You all have my email.